long waiting time. I call him the magician of the shoulder or the superstar. I have my own terminologies, and I still feel it's not going to be wrong. It's none other than Dr. and Professor Dr. George ATHWAL. I had the pleasure being with him, and with very few words, he has got the skill and art of teaching, demonstrating, and it's always pleasure to see him in work. If you leave me, I will be talking for the next 30 minutes about him, and I would say even Dr. Senthil and all the other guys would so. And I think he has in 45 minutes a surgery, and it's been so kind of him accepting our invitation to come online and teach us the tricks. And I don't think I need to give a proper introduction apart from this, because he's a global leader in the shoulder. So I leave all the stage to him. Thank you, Professor.
Wow, that was such a wonderful introduction. I'm embarrassed.
Now,
I'm just, I'm just
you're being
a
humble. You're being humble. I agree. Dr. Sendil will agree with me on this.
And
oh,
again, Professor, just regarding the reverse, and we've read so much of your papers and listened to so many of your talks and so many podiums, and it's a real pleasure to have you online and so that to directly interact you. So over to you. Please go ahead with your presentation.
absolutely.
Yeah.
Thank you so much. So what I'll do is I'll share my screen.
Yeah.
I should be used to this now since COVID. Everyone is so
Yeah.
convenient now to have this technique. So can you see my presentation?
It's sound and clear. It's sound and clear.
Okay, good. Wonderful. So I'm going to talk a little bit about reverse for fracture. And this is an area that's very interesting to me because certainly it seems like this is becoming much more common now. Many patients have proximal humerus fractures, and there's a lot of controversial literature out there with respect to non-operative management. I know personally my indications for non-operative management have increased since that paper came out from the UK. But still, some patients are active. They have widely displaced fractures, and so they certainly would benefit from reverse shoulder arthroplasty. So that's what I was going to share with you over the next 45 minutes. So this is my outline. I was going to talk a little bit about the various implants out there that are available. And then I was going to go into the technique, and there's many different techniques out there on how to do suture management and how to do a reverse for fracture. I'm just going to share with you one technique, and this is just a technique that has worked for me. I'm not telling you it's the best technique, but it's been very reliable for me. How do I recreate the correct version or humeral torsion at the time of surgery? And also humeral head height, which is very important when we're managing a patient for reverse for fracture because the tuberosities are now off. And so we have to determine how high do we put that implant. And I do have a technical video. You may have seen this video before. It's online, but it's a video of me doing a reverse for fracture. And finally, I'm going to end off with a little bit about the outcomes. And the outcomes are actually quite good with reverse for fracture. Patients do get reasonable functional recovery, not as good as an elective reverse, but still much better, and I'd say much more predictable than a hemiarthroplasty. And then finally, we're just going to end off and talk a little bit about the pitfalls because this is a technically challenging operation, especially when everything's fractured, and just go through some of the problems that you may encounter and how to avoid them altogether. So when we talk about a fracture stem, there's fracture-specific stems and there's regular stems that we use for standard reverse shoulder arthroplasty. And really, if you look kind of critically at the literature, there's no literature that's demonstrated with a certainty that a fracture stem is absolutely required. So certainly you can use any stem for fracture reverse. However, my preference is to use a fracture-specific stem because I think it has certain features in it that may make the operation a little bit easier, but it's not absolutely necessary. Some of the things that I like about a fracture-specific implant is that it's lower profile. I hope my pointer comes up, but you can see here that it's a little bit narrower here, so it allows you to do some bone grafting and also to secure the greater and lesser tuberosity. The other thing typically about a fracture-specific stem is it has bone on-growth potential in areas where you're going to place the tuberosities. And so many times you have metaphyseal fitting stems that may not have a bone on-growth surface at the metaphyseal junction. And with a fracture-specific stem, there's a greater chance of that because it's designed specifically to, get the tuberosities to heal. And then obviously with a fracture specific stem, it's going to have suture holes or be compatible for suture fixation. So with this particular implant here, this is the one that I use. That's why you're seeing a picture of this. And I am conflicted with this implant, is that it's got a polished area right here along the medial calcar where you can pass your sutures around. And it has a hole here for bone grafting, but you can also use this hole for individual suture passing. Now, finally, whether you choose to use a fracture-specific stem or any elective reverse stem, I think one of the most important things, you still have to use a standard length stem. My recommendation is we should not be using short stems or worse, stemless for fracture. So we need a regular length stem. The reason is that if you look here, we're going to have a fracture up here. So we need to have diaphyseal stability when we're managing a patient with a 4-part proximal humerus fracture. So short stems, although they're possible, you can do a short stem in a setting of fracture. It's not ideal. So with the different types of stems out there, there are really 3 styles. Certainly, absolutely, the gold standard is a cemented humeral stem. And the reason that is that when the tuberosities are fractured, we lose our metaphyseal stability. And so we have to obtain diaphyseal stability. And arguably the easiest way to get diaphyseal stability of your stem is with cement. So you can see here on the right, the stem has been put in cemented. I would tell you, up until 2 years ago, I was doing cemented arthroplasty on everyone that had a proximal humerus fracture that needed a reverse. Lately, I've transitioned to press fit and press fit with screws, but certainly I would tell you the literature would say still that cemented is the gold standard. Then there's also press fit styles. So with press fit, what we have is it's going to be at the metadiaphyseal junction, there's going to be a flare, and then you're going to have typically 1 millimeter increment size stems, but some stems do come up in 2 millimeter increments, but typically 1 millimeter increment sizes so that you can get that metadiaphyseal stability with just the press fit. Now, there's going to be certain patients that you're not going to be able to do that. And those are patients that are very osteopenic. If you're trying to get a press fit in a very osteopenic or an osteoporotic patient, you risk fracture. And also in patients that have proximal humerus fractures that have diaphyseal extension so that the fracture lines go down towards the diaphysis, you have to be very careful about trying to get that press fit. And then you have this third option, which I've listed here as press fit with screws, but it really is uncemented with screws. So your goal is not to get rigid fixation with press fit, but you want to get good fixation, and then you can augment it with screws. And there's many different implants out there that allow you to do this. This one here on the left, you can see that you have locking screws here. I have no affiliation with this company, and this will provide you with stability. I have several friends that use this stem, and they find it very effective for managing patients with proximal humerus fractures. Now, I wasn't going to go through truly the surgical indications for managing patients with a reverse fracture. The reason is it's so controversial. There's no clear guidelines on which patients you should offer reverse fracture and which ones you should conduct open external internal fixation, whether with a plate or with a nail or with wires, and which one we should offer non-operative management. I think the best way to do that is we each individually have to review the literature and decide what we're comfortable with. So those are really the indications are very quite soft right now for all 3 management options, non-operative, open external internal fixation, and for arthroplasty. So I think each surgeon has to make an individual decision. But with respect to preoperative planning, I personally believe preoperative planning is so important when it comes to doing any surgery. I like to think about the operation the morning before, or even sometimes the evening before, and systematically go through it. And as I go through the operation, I think of the challenges that I'm going to encounter. So it's very similar to a pilot flying a plane. They have to do a pre-flight checklist. They check the plane, they make sure they have everything they need. They get an idea of how far they're going to fly. Is there going to be bad weather along the way? Are they going to have to bypass the weather? Is there turbulence? They're prepared for the flight. Just like us as surgeons, we absolutely need to be prepared for surgery. And there's no disadvantage in that. No one has ever said to me, geez, I prepared for surgery and that was a problem. No, it's only going to be good for us and it's going to be good for our patients. So you get standard x-rays. Typically on the x-rays, you're going to decide how you're going to manage the patient, whether they're going to get non-operative, operative, and whether it's going to be fixation or arthroplasty. It's the x-rays, the classification of the x-rays, and then also patient factors that help me personally decide. So the patient factors are, are they younger? Are they active? What sort of activities do they do? Are they sedentary? Are they demented? So based on a lot of those patient factors, it's going to help me decide the surgery. Means if a patient is demented, admitted to a care facility and really has no function, many of those patients are going to get non-operative. Versus you may have a young patient in their 30s and 40s with a complex fracture that you're going to do everything possible to fix it. And then you have a patient that may be, 75 years or 80 years old, that's still very active and has a displaced fracture, that you may end up doing a reverse shoulder arthroplasty. So once again, you're going to look at the x-rays, we're going to classify the x-rays, and then we're going to look at the patient factors, and using a combination of those three, we're going to determine our treatment algorithm. And so I tend still get a CT scan. The reason I get a CT scan is it gives me so much more information. I've never been disappointed getting a CT scan to help manage a patient with a fracture. It rules out a glenoid fracture. Many times we look at a fracture such as this and we say, this is a 3 or a 4-part proximal humerus fracture. There's a component of a head split because a portion of the head is still attached to the greater tuberosity. And we'd forget to look at other associated fractures. Many times you may have a non-displaced glenoid fracture, or you can have a displaced glenoid fracture that you can completely miss because our eyes are so concentrated on looking at the proximal humerus. You can have acromial fractures, scapular spine fractures, scapular body fractures, and those may come into play if you're choosing to operate, especially if you're choosing to do a reverse and you miss that there's a minimally displaced glenoid fracture. That's going to make glenoid base plate positioning and fixation challenging at the time of surgery. So I love CT scans. I think it's standard of care. It's no longer is it advanced imaging. Now, with respect to the CT scan, we can also look at diaphyseal extension. Is there any extension that's going down in the shaft here that may make fixation of your stem or fixation with open external fixation challenging? So here is the 3D CT scan of this particular patient. And the first thing that you notice is that here's the biceps groove. Here's the lesser tuberosity. And this is a very typical greater tuberosity fracture, in that you see that the anterior portion of the greater tuberosity, the 6 to 10 millimeters of the anterior portion, is still attached to the bone in the biceps groove. And this may or may not be attached to lesser tuberosity. And so most, not every, but certainly the far majority of greater tuberosity fractures do occur in this location right here. So the supraspinatus is going to be split. A portion of it is going to be attached here, and a portion of the supraspinatus and infraspinatus are going to be attached here. And so you can see this does create some challenge in that what are you going to do with this portion of the supraspinatus that's still attached to this fragment? This is a very typical fracture pattern. And so you can see this is the split that you're going to encounter. So how do I manage this in the operating room? Well, with respect to the exposure, there's really two exposures for reverse fracture. There's the standard delta pectoral exposure, and then there's a superlateral exposure. My strong preference is to do the delta pectoral, and the reason I prefer to do that, that's my workhorse incision. I'm very comfortable with that incision. So I tend not to do a superlateral, but I have several surgeon friends, and I know as many people in India also do a superlateral approach, and that's absolutely okay, as long as you're comfortable with it and you feel you can manage the complications as they occur. For me, the delta pectoral incision is much more versatile, and that's why I choose to use that incision for reverse fracture. And then once you've done your incision, putting your retractors in, you're going to come across the biceps tendon. You have to decide what to do. My preference is to cut the biceps tendon and to tenodese it to the pectoralis major. And by identifying the biceps tendon and doing the tenodesis, I immediately know where the biceps groove is. And if I look back at my CT scan in my mind, I know that I follow the biceps groove. The biceps groove fragments attached to lesser tuberosity, and then there's going to be the greater tuberosity, which is going to be about 8 to 10 millimeters more lateral or posterior than the that biceps groove. So it kind of helps me orient myself. And what I do, and this is also controversial, is that portion of the supraspinatus, if we go back one slide, that's attached here, I actually just release it. I actually do not save it. I release it. And the reason I release it, it gives me good visualization of this fragment. It also gives me a visualization of this portion of the posterior greater tuberosity, because this is going to be my landmark for where I'm going to secure the greater tuberosity on the stem. So I actually release that portion of the supraspinatus. And then once we've done that, so we've released that portion of the supraspinatus, I'm going to go ahead and split the tuberosities, just move them aside, evacuate the hematoma, remove the humeral head, but I'm going to keep the humeral head because I'm going to use it for bone grafting. And then I'm going to place tagging sutures. I'm going to put a tagging suture around the lesser tuberosity, a tagging suture around the greater tuberosity, and then I'm going to go ahead and expose the glenoid. I'm going to go right to glenoid and put in my glenoid base plate. But I will tell you is once I've put in my glenoid base plate, I don't go to my provisional fixation for my tuberosities. I actually, I pass my sutures and then put on the glenosphere. And I'll show you that all in the video that's coming up. Now, with respect to placement of sutures around the tuberosities, as I mentioned, there's many different techniques out there. This is just the technique that I use. And the reason that I use this technique, it's easier for me. It helps me with my suture management. So what I do is I use nice loops or just regular suture loops. And you'll see that in the video. And what I do is I place 5 loops around the greater tuberosity. And I'm placing them down here. So this is the supraspinatus. This was that anterior portion of the greater tuberosity still attached to the biceps groove. I've released the supraspinatus here, but I can see this portion of the supraspinatus. I tend not to put sutures up here. What I want them is, I want them in the teres minor and the infraspinatus because I'm going to wrap the tuberosities together. So I want to place sutures here. So I go 1, 2, 3, 4, 5, and you can see that you can use nice loops, or you can just use a suture with a needle to go in and then back out to create this loop. And I try to use different colors. So I'll have like a dark suture, a light suture, a dark suture, a light suture, and a dark suture. And the reason I like to do that is I have different expectations or different jobs for each one of those sutures. And so then I also sometimes place a suture down here by the diaphysis. So we're going to go ahead and put in our stem. And then once I've placed my stem, I'm going to use the 3 darker sutures to secure my greater tuberosity, like that. And these suture loops are going to go around the medial calcar of the stem once I've stabilized the stem. And then I'm going to tie them and provisionally stabilize my greater tuberosity or reduce my tuberosity. But you remember, I still have the 2 other white sutures. What I do with those 2 white ones is after I've got everything reduced, the shoulders in, I pass the 2 white ones, which each one is double loaded. So this is 4 sutures, 2 loops. I pass them around the lesser tuberosity. And so that allows me to fix the tuberosity to the greater tuberosity circumferentially around the stem. And I'll show you this all in the video. And then finally, we have our diaphyseal suture, which was this one back here. And this one typically I use to just close up that rotator interval right there. So the remaining leading edge of supraspinatus to the upper edge of subscapularis, and secure that to this hole. Now, what about humeral torsion or retroversion? Many ways to do this. Some people just standard place the implant in 20 degrees of retroversion. Some standard place it at 30 degrees retroversion. What I tend to do is I look at the humeral torsion, or what I call the metaversion. This was a paper that was published by Danny Goyle. He was one of my fellows probably about a decade ago. And so if we're looking here, when we look at the proximal humerus, it has this egg shape to it. So here's the diaphysis. We're looking down axially at the humerus. And what you'll identify is that there's a apex here, which represents the neck of the humerus. And the neck of the humerus points to the version of the humeral head. And so that makes sense. If you think of the femur, the femoral shaft comes up, there's a femoral neck, And then on the femoral neck, there's a femoral head. So the neck of the femur points to the femoral head. And so in this case, the neck of the humerus, there's usually this metaphyseal calcar region points to the head. So I use this as the version. So I look for that point. And so this is going to be the orientation or the torsion that I'm going to go ahead and push my humeral stem in. So let's go into the video. So this is a patient that has a 4-part proximal humerus fracture. I hope that video is playing well. I'm going to go ahead and make my delta pectoral approach. And what I'm going to look for here is Morenheim's triangle right there. That's the medial insertion of the deltoid onto the clavicle. And once I find that, I'm going to go ahead and create my delta pectoral approach, as you can see here. And the first thing I go for, as I mentioned already, is I'm going to go right for the biceps tendon. I'm going to tenodese the biceps tendon. Then I'm going to split the tuberosities. The lesser is going to go medial, the greater is going to go lateral, and then I'm going to take out the humeral head. So here comes the humeral head, and we're going to save that because it has a lot of good bone on there. And then once we've got the humeral head out of the way, we can have access to the tuberosity. So here's the lesser tuberosity. So I'm going to place a tagging suture around the lesser. This is superficial to deep, and then the same needle goes now deep to superficial. This is a number 2 fiber suture, and so it creates a loop. So there's my loop. I'm going to snap it. And this is my tagging suture for the lesser tuberosity. And I'm going to do the exact same for the greater tuberosity. Superficial, deep, deep, superficial around the tendon to bone interface. And now I've got my lesser tuberosity tagged. I have my greater tuberosity tagged. And as I mentioned, now I'm going to go to the glenoid. And glenoid exposure is typically going to be relatively easy because the tuberosities are missing. So I'm going to remove the labrum, remove the cartilage, as you can see here, and then you have very good exposure of the glenoid. When I'm doing a glenoid for reverse for fracture, I typically do not lateralize to the same degree that I do with a primary. So in this case, the implant I choose to use has a +3 base plate and then 2 millimeters of additional lateralization. So I'm lateralizing about 5 millimeters here, while typically with elective reverses, I'm lateralizing almost 10 millimeters. So here I am putting my base plate in. I'm going to secure it. And what we have to remember is these patients have relatively soft bone. They had a fracture. The reason they had a fracture is because they have poorer quality bone. So we have to be careful not to fracture the glenoid. So I'm putting my base plate. And now before I put in my glenosphere, I'm going to go ahead and pass all my 5 sutures around the greater tuberosity. And the reason I do this, there's more area to work with it. So what I'm doing now is I'm transitioning to a cadaver video. This is a video of me doing the surgery. And the reason I'm doing this is it's much easier to show my suture placement on a cadaver here. So these are the loops. And I'm going to place 5 of them. 1, 2, 3, 4, 5. I'm going to start inferiorly on the greater tuberosity as low as I can. I'm going to place them through the tendon to bone interface. So there's my first loop. I always pass my tagging suture superiorly so that it doesn't get tangled. So I cut the needle off. There's my first dark green loop. And you can use any suture for this. And now I'm going to snap it and then stack it onto the Kelly. Here's my second one. And I remember I mentioned I like to use a lighter suture so I can distinguish the difference. So here's a white one. Pass my tagging suture over the top, cut it, snap it, and then stack it. And you can choose to do this just with a regular suture also, meaning that you can go superficial to deep, deep to superficial, and that also creates a loop. Here's my third one, going deep to superficial, this loop, cut the needle off the loop, snap it like so, and then I'm going to stack it. And the reason I'm stacking it, it allows suture management. Here's the second white suture, and then we're going to end off with the green. So we have 5 loops all going around the greater tuberosity. There they are. And now I'm going to go ahead and just snap these to the drape to get them out of the way, just like that. So now I've removed all the sutures are posterior. Now I can go ahead and put on my glenosphere. So we're going back to the surgery. I'm putting on my glenosphere, impact it, and set the safety screw. Just like this. Now, once I've got my glenosphere on, I'm going to deliver the humeral shaft. So I'm taking the humeral shaft, I'm going to deliver it through the incision, and now I'm going to start preparing. So in this case, I'm going to use a fracture-specific stem with screws. As I mentioned, you don't have to use a fracture-specific stem. You can use any stem that you wish. I do like to use fracture stems because they have these marks on them, and they make it a little bit easier to do the surgery. So I'm going to go ahead and bang in some broaches, and so I'll start broaching up. And what I'm looking for, so I'm going to use an uncemented stem here, is what I'm looking for is axial stability and rotational stability. So here, so there's axial, but no rotational. And we'll just keep on going up in 1 millimeter increments. Impact it, pull it, and twist it. So here we have axial and rotational stability. So this is the right stem size for me. And now I'll go ahead and do a trial reduction. Now, what I'm looking for the height is I want to get an idea of the height of my greater tuberosity fracture. And typically the upper portion of the rotator cuff footprint is aligned to the upper portion of the stem that I choose to use. And so that gives me an idea of the appropriate height. So I'm bringing the tuberosity in, and I'm going to see, does it reduce to the shaft, and does it reduce to the upper aspect of the stem? And if it does, that's the correct height. So now I'll take off the polyethylene. I haven't chosen this polyethylene. And now another option with this particular stem is this extra jig that allows you to now save this height. So I'm putting down this tab, and this tab in this particular case will now save the height of this broach. We don't have to do this. You can use a ruler or anything to measure that height and then recreate it when you put in your true stem. And so now I'm just going ahead and going to put a suture, the last one, through the diaphysis. Just like so. So now here is our true stem, and now we're going to place some bone graft into it. I must admit, putting bone graft into the center of the stem is not absolutely necessary. It is certainly an option with this stem, and so that's what I'm doing right here. I'm harvesting the bone from the humeral head with this particular jig, and now I'm going to go ahead and bang that into my true stem to enhance the bone graft. So there it is. There's the true stem, and there's the bone graft in it. And now what I'm going to do is I'm going to put some drill holes just adjacent to the bone graft so I can pass some sutures through it. So here's my true stem on my jig. And we're going to go ahead and implant it like so, impact it to recreate that height. There it is. Let's check it axially and rotationally. It's stable. There we go. And now in this particular system, I'm going to go ahead and use the additional screws. So this is an anterior to posterior screw that you can place through your deltopectoral incision to provide additional stability if you're choosing to use a non-cemented stem. If you're using a cemented stem, which is absolutely the gold standard, I would cement the stem right now. But in this case, I'm going to go ahead and put the screws in. So here's, I'm drilling, I'm measuring. I can choose to use this depth gauge here. And then we'll go ahead and put the screw in. There we go. So this is going to be a locking screw anterior to posterior. And now I also have the option of putting diaphyseal locking screws in. Now with diaphyseal locking screws, we have to be careful about the location of the axillary nerve, because this is typically designed to be placed in with the shoulder reduced. That's how, when you do IM fixation. But in this case, we have the shoulder dislocated because we're putting in a stem for reverse. So I'm going to maximally internally rotate. And what you can see here is once I internally rotate stem, because I've locked it with the AP screw, it leaves the deltoid and the axillary nerve posterior, so it's safer. And so now I'm going to go ahead and put in these diaphyseal locking screws. And so this is an uncemented application of this stem. So there I make a small little poke hole. You can see that the deltoid and the axis nerve is much more posterior. I'll work my way down to bone. Sorry about that. I'm getting a lot of pages. I'm on call right now, so hopefully everything's okay. So now I'll go ahead and put in my diaphyseal screw. So I'm going to drill it. I can measure off the drill, or I can measure using a depth gauge, and I'll put in a diaphyseal locking screw. I'll put 2 of them in. And so this is going to provide that additional stability for uncemented utilization. And once again, I'll say it again, I still believe that cemented stems are certainly the gold standard with fracture reverse, but I'm transitioning to using more uncemented stems, really because they're just a little bit faster, and I feel they're probably the same. So now we've got 3 locking screws into our stem. I'll go ahead and remove the jig. And what we can do again is we can trial one more time, because now we've set the height. And now if our height is incorrect, we still have the option of using thicker polyethylenes or also a spacer that builds up. So now what I'm going to do is, because I mentioned earlier on that the medial calcar portion of this stem is smooth, so it doesn't have any bone on growth, but it's really designed for suture passage. So here are my 5 loops, so 10 strands. I'm going to pass them around the medial calcar for my greater tuberosity from posterior to anterior. And here is in the cadaver again, just so you can see it. So I have my 5 loops. I'm going to pass them all around the medial calcar. Now, if you choose to, so we've passed all the major fixation sutures. This was that tagging suture that I placed on the greater tuberosity, and you can choose to use this for additional fixation. So you can pass this through the hole, the large hole in the center of the implant. And this is the suture that I'd placed on the lesser tuberosity as a tagging suture. I'm just going to pass that too, just to provide some additional provisional fixation. And so with the lesser, I'm going to pass it anterior to posterior, and with the greater, I'm going to attach it, pass it the other way. So there's my polyethylene, my true polyethylene. I'm going to go down and I'll reduce the shoulder. And so if I've used my tagging suture, as you can see here, for fixation, I'm going to go ahead and tag it. This is going to be, I'm going to go ahead and tie it, pardon me. And this is going to be my provisional reducing suture for my greater tuberosity. I want the upper aspect of the greater tuberosity to be flush with the upper aspect of the stem. And ideally, I want 1 or 2 millimeters of overlap of the greater tuberosity on the lateral aspect of the diaphysis. So now we're going to go ahead and do our definitive fixation for our greater tuberosity. Remember, we had 3 dark sutures and 2 white ones. We're going to tie all of our dark sutures. So here we go. That's the first one. And I'm going to use a racking, locking hitch knot. Here's the white one. The second one, I'm not going to tie that. Here's my third one. I'll tie this one. Just provisionally putting the niece knot or the racking, locking hitch. I'm not going to tie the third one. And I'm going to tie here. Sorry, that was the fourth one. Here's the fifth one. So I've tied 3 of the dark greens. And then once I've tied them, I can go ahead and back them up. So I'm going to tension them again and then really stabilize them. And so now I've got rigid fixation of my greater tuberosity. I tied the first tagging suture and then the 3 loops, which each is 2 sutures. So here are the 2 remaining whites. And as I mentioned, I've reduced the shoulder, and now I'm going to pass the white sutures deep to superficial around the subscapularis tendon, just like that. And so what these sutures are, they're going around the greater, around the calcar, and now around the lesser tuberosity. And I'll pass the other one. So I've passed both of my white sutures, those remaining whites, around the lesser tuberosity. Now, and I do this right at the end because it just helps me with suture management. So remember that tagging suture that we put on the lesser. I'm going to go ahead and tie that tagging suture now. And this is going to provisionally reduce the lesser tuberosity. And now I'm going to definitively stabilize the lesser and the greater to the shaft, tying those two remaining white sutures. Now, these are going circumferentially around the greater tuberosity, the medial calcar of the stem, and around the lesser tuberosity. So there's my knee knots, and now I'll back these up. There we go. So we've tied both. And now we have our last diaphyseal suture that we place through the diaphyseal portion of the humerus. And that's just going to close up the rotator nerve. So the leading edge of the remaining supraspinatus, just to provide some additional stability. I have to be honest, I don't always use this suture if I have great fixation with my other sutures. And then we'll bring in back to our patient, we'll bring in the C-arm. And what we're looking for is that reduction of the greater tuberosity, where the upper portion of the rotator cuff footprint, as you can see right here, is attached onto or collinear with the stem. And so here's this patient at 6 months follow-up. So here's the tuberosity. The upper aspect of the tuberosity is lined up to the stem. A little bit of overlap here of the greater tuberosity on the lateral aspect of the stem, just to provide increased bone surface. And we have locking screw fixation. So what does the literature say about reverse refracture? Well, as I mentioned earlier on, it is controversial whether we manage these patients non-operatively with fixation or with arthroplasty. But certainly each surgeon has to individually come up with their own indications on how they're going to do that, because right now most of the literature is a little bit controversial and confusing. But certainly if you choose to manage your older patient that has a widely displaced fracture, but who's still very active in the community with a reverse shoulder arthroplasty will lead to predictable outcomes. Now, this is an excellent paper published by my good friend Joaquin Sanchez that really summarizes the literature on reverse for fracture. There are some trends. The trends are people seem to be trending to using more uncemented stems, although the gold standard is still cemented. People are also trending to using more fracture stems than regular stems. And finally, what's absolutely important is we have to get absolute rigid fixation of the greater tuberosity. If the greater tuberosity heals, those patients have significantly better long-term outcomes. So what are the pitfalls to talk about? Well, missing a glenoid fracture. That would be a pitfall. Incorrect version, excessively retroverting or excessively anteverting. So you want to look at the metaversion as I describe it, or you can just put everyone at 20 degrees of retroversion. Incorrect height. This is a common problem. And with incorrect height, typically what's done is the implant is placed too low because the greater tuberosity and the lesser tuberosity are off. And so the implant's placed too low. And so you lose height, and those patients may develop problems with instability. And finally, and most importantly, a pitfall is poor tuberosity fixation. So we really have to get rigid fixation of the greater tuberosity and the lesser tuberosity, and we have to bone graft them. We have to do everything possible to promote healing. And so that's all I was going to share with you with my tips, tricks, and outcomes of reverse for fracture. I'd also like to invite everyone out to the International Congress of Shoulder and Elbow Surgery, the ICSES meeting, which will occur in Vancouver, British Columbia in September of 2026. Visit our website. It's going to be a great meeting. Thank you so much.
Thank you. It was absolutely mesmerizing. And now I think everyone agree why I call him the magician. Captivating talks. Without waiting a lot of time because he has on call and things, so we'll quickly go on to questions. Just, is it okay, Prof, we ask you a very few questions?
Absolutely. I'm just going to drink some water here.
I think you covered it in your own fashion of captivating. You've covered all the talk just for the audience perspective and to make it clear. Always the swindling question of how young is too young. So you made the point very clear. Just to ask you a personal question, what was your youngest patient for fracture reverse on a personal perspective?
So say that one more time.
So the talk, controversy on how young is too young for a patient to go for a fracture reverse,
What's
which is,
eng?
I mean, the age limit,
Oh, age.
limit.
I haven't used that term, eng.
So the age limit. So just you made the point very clear. Just for our understanding, what in your personal experience was the youngest or the lowest age limit for
I
whom?
think, it's such a tough question to answer. And I think personally, I have done reverse refracture in someone that's in their 50s. I don't think I've done it in their 40s.
Makes it
The
clear.
other, yeah, the other thing is that many times if someone is in their 50s and they've got a nice, robust greater tuberosity, I'll consider doing, rarely, I'll still consider doing a hemiarthroplasty to get everything in the perfect position in hopes that it may heal. And if it heals, we still know that hemiarthroplasty does well if it heals. And typically, if I'm going to do that, I use a platform stem that if it does cause problems, I can relatively easily convert it to a reverse. And in younger patients, even if it's, I've had a younger patient that had a head split fracture that I still fixed because even if they had a high rate of AVN, if I could put the greater and lesser tuberosity in the correct position, many patients can function relatively well with AVN. They have AVN, they have some pain, some poor motion, but they're still, it's probably still better if they're in their 30s to have AVN and manage that than it is to put an arthroplasty in at such a young age. So it is so, as you mentioned, it's just so controversial of what to do.
You made it very simple and clear for us.
So, Prof, excellent and amazing talk. It's always, amazing to, keep, listening to you. You make things very clear, crisp, and, easy to understand. Thank you very much for the talk. But deltoid tension, as you mentioned, you clearly, it's always the holy grail, probably in the reverse, because we are heading towards, the ideal tension. And in reverse, it's much more difficult in a fracture situation. And there are already, you showed the height of the fracture, which can be managed. Obviously, there are other few pointers like, conjoint tendon tension and, reducibility, all you mentioned. But there are, a few sensors which are available. I mean, it's available getting around in the market.
Hmm.
So, where the wireless sensors, what is your opinion on them? I mean, do you think that is a way to go, or is it still too early? If we actually have a poly which is having a sensor
Yeah,
which measures the tension and gives us, yeah, your
I
opinion on
think,
that.
oh, totally. I think the more information that we can gather, I think the more we're going to learn. So I would never say right now that a sensor is not useful. I would say we need that information. Once we get that information and analyze the information, in the end, we may find out that yes, a sensor is definitely helpful because we know that we have to put in the tension at between, 60 and 80 newtons or something. Or in the end, after investigating this, we may find that it's just too variable and we don't need sensors. But I would say if we have the ability to capture that data, I know several ortho sensor exists. There's several companies out there that exist that have polyethylene sensors. I would say certainly we should gather that data. It's only going to be helpful the more we understand this. Do I use sensors right now? No. Uh, may I in the future? Absolutely. We actually did a study very early on, almost 8 to 10 years ago, looking at sensors in reverses. We did it in a lab, but no one was interested in it at that time. But as it's nice to have everyone interested in now.
Thank you.
Thank you for the excellent answer.
Yeah.
Prof, the other perspective you made us clear is that how important is it to approximate the tuberosities for the outcome of the patient, which is in slight contrary to the general setting of the reverse. So what was your personal experience in patients who had difficulties of the tuberosities healing? Were they absolutely bad? And what, I mean, you are the dictionary, you know the things, you have seen a lot. Guide us.
What, so there's a couple concerns. The first is, if you don't fix the tuberosity, I think patients will still get good motion. Like many times you don't fix the greater tuberosity or lesser and they have excellent motion. They have unpredictable external rotation. So I've actually had some patients where I fix the tuberosity and it completely resorbs. It's gone. And then at a year, they have great motion and they have great external rotation. And I can't explain why they're doing so well when the tuberosity is missing. But saying that, I also have the same patients where the tuberosity was excised or didn't heal and they're doing poorly. They still have good motion forward, but they can't externally rotate. Now, one thing I have noticed is that the rate of aseptic stem loosening is much higher if the tuberosities are not healed, because most stems are circular. If the tuberosities are missing, there's all this rotational torque on the stem, and there's a higher rate of stem loosening. So I always try to fix the greater tuberosity. Sometimes I don't always fix the lesser tuberosity, I have to be honest, but I will always, always, always try my best to fix the greater tuberosity. Great.
And so thank you. There's, you already briefly, touched upon, your lateralization. I know you're a big, bio-RSA, person, and that is inherently for the arthritis patients, but the fractures is a completely different scenario. So again, because the capsule is not contracted, patient had a normal shoulder before the fall. So again, wanted to know your thoughts, whether you at all lateralize at all, or would you use any bone graft? Because I saw in your videos that in the glenoid you didn't really lateralize it. So what are your thoughts? I mean, are we going to be pushing the boundaries in looking at the data in the future and seeing, yeah, maybe bio-RSA may be the way to go, or no, we should be just sticking to the native glenoid?
Yeah. So I lateralize about half as much with fracture. I don't, with, electives, I may be lateralizing 8, 11 millimeters, but with fracture, I'm typically lateralizing 5 millimeters. And the reason is the more I lateralize, the harder it is to get the greater tuberosity around. And so I cut my lateralization in half, so it makes it easier for me to fix the greater tuberosity. It's really about the tuberosity for me. If I had a better way of fixing it, maybe I would lateralize more. But right now, with sutures, I decrease my glenoid lateralization to decrease the tension on my tuberosity. All right.
I think one last question, and we'll let you go back to work.
I might have
Probably
to
the
go.
last one. Yeah.
Okay. We'll do one last one. I have to run to the
question.
opera room.
Last question. Yeah.
So I think you've covered all perspective, Prof. So I wanted to show you cases, something. I think we'll stop it on matter of time. You explained us beautifully on the version, how intraoperatively the bone is. Do you ever do a normal shoulder referencing for version calculation? And part B of the question, have you used bone grafting in an acute fracture scenario, not for filling the stem, for helping us with the offset management, or it's never a case in acute setting?
So I don't tend to use, I'll use bone graft in the stem for tuberosity fixation. I tend not to use it for stem fixation. I'll use the stem to obtain the stability. If I can't get stability with the stem, then I cement for sure. With respect to version, I tend not to use the contralateral side because with the meta version, it gives me the true version on that side. So that's what I tend to use that. All right.
Sure. Thank you very much, Prof. I think it's been amazing, talk and having the discussions. Hopefully, we'll meet soon in person, and we'll pick off your brains more. Thank you very much.
We can also have a part 2.
Yeah.
Thank you so much, Prof. I know we would like to catch you up for more time, but I've been with you. You are a busy guy, really busy guy. Thank you so much.
Thank you very much. Thank you, OrthoTV.
A good evening. Bye-bye.
Thank you. Bye.
Thank you.